Hi, my name is Jessica Cash. Welcome to the Salt Health Podcast. I am here today with my co-founder and husband, Jordan Cash. I'm really excited to get to interview him today. We've not brought him on. I've brought a lot of our team on and look forward to continuing to bring more of our experts on to provide you more information about functional medicine and the things we're doing here in Northwest Arkansas. But today, I want to talk to Jordan about healthcare administration. He has almost 20 years in the healthcare administration world, and he brings a really unique perspective to our to Salt Health, but also to our partnership. And so, welcome.
Thank you very much. Yeah, exciting, but also a little strange to be interviewed by my wife. But this is awesome, and obviously we work together daily at Salt. And with our amazing team, we're super blessed to be able to be in partnership together in life and also in business.
Yes, I love it. So the first thing I want to introduce you to people who don't really know you. Tell our audience a little bit about your background and, how we got here to Salt Health.
Yeah, so obviously, healthcare administration is a field that a lot of people don't necessarily think about or know a lot about. In fact, I remember early on somebody asking me, well, don't the doctors just run the hospitals or run the health systems? And absolutely, physicians can be CEOs or hospital presidents or administrators of facilities. But a lot of times there are business leaders who are very engaged in that process. So I actually did go get a master's in healthcare administration as a degree. And I am currently a fellow of the American College of Healthcare Executives as well. And so over the last 20 years, I've had the opportunity to work with amazing physicians, providers, nurses, respiratory therapists, you name it, dietary workers across the entire healthcare spectrum, whether that be inpatient facilities, outpatient facilities, surgical centers, physician clinics, durable medical equipment, home health, hospice, you name it. Kind of over the last 20 years, I've had the opportunity to serve in both rural and more metro urban areas, in small hospitals, also medium-sized up into 500 plus bed hospitals where we've done major transplant surgeries and transitioning to the highest level of care. And so my healthcare experience and background has definitely allowed me to gain, I think, a little bit of a unique perspective by having that wide spectrum of services offered. And serving in multiple different roles, including all the way, into, a hospital president or chief hospital executive role.
I often tell people when they ask about our journey, our Salt Health journey, I felt like I always had a front row seat in your career. We moved around a whole lot, got to be in a lot of different communities, some metro, some rural, but we grew up in rural Oklahoma. And I think that's where a lot of our heart comes from, access to care and quality care is such a big deal. And when you talk about rural areas, it's a major deal. It's a major issue of having quality care for patients. And so I was blessed to get a front row seat of that and get to be part of a lot of those communities and really help drive personalizing medicine. And I think that's, I would say that was one of our foundations for Salt Health.
Yeah, no question. And most of my career was with, one health system, but worked for more than one. And both the systems that I spent time in had both rural and metro operations and services available to the communities. And there's no doubt that, I love that approach of being able to provide exceptional rural healthcare to those who may not have the best access. And so as we transitioned and had the opportunity to start something new with Salt Health, I think that's something that always is a part of us. It also with Dr. Herbst, our chief medical officer, having served in rural areas as well as, with the Cleveland Clinic, obviously in a metropolitan area. But you can tell that it's the heart of our leaders, our founders, as well as many of our team members, is to improve the access to care to all individuals in our country, including those who maybe don't have the best access.
I love that because Dr. Herbst also has that heart. As co-founders, there are so many amazing people in the medical world and people that are making strides and changes and changing lives, but it's overall a broken system, right? Would you say it like that?
Yeah. So I definitely want to be able to shed some light and insight into the traditional U.S. healthcare system today with a few highlights. I kind of, as I was preparing a few thoughts, I even kind of joked. I was like, maybe we should call it like scary or alarming statistic hour with Jordan. And I don't want to do that. At the same
Jordan's
time,
a numbers guy, in case you guys didn't know. He's our number. We need this.
But it does recognize and highlight, like I said, a few of the challenges. And so we just talked about access. So I think a great, statistic to potentially lead with is, it's estimated at 83 million, which is almost 25% of the U.S. population, currently live in areas without a sufficient access to a primary care physician. And we've been expecting that physician shortage and that access shortage, would continue to grow, and estimates are pretty scary into the future with that. It was part of what, helped lead us to launch into Salt Health. But more specifically, what was a burning desire for starting Salt was not just the access, but the amount of time and the quality of time that you get with your healthcare team.
Well, so let me jump in there. Tell us why primary care. I mean, you mentioned a shortage in primary care. Why is that important? What do you care? I mean, I would venture to guess that a lot of people would say, I don't have a primary care doctor. I have someone that maybe I visit for insurance reasons once a year for my annual exam, or I visit an urgent care. Is that primary care, or is there, a better reason for you having a primary care doctor? Why is that such a unique gap in the system?
Well, there's no question that a lot of people use an urgent care or even an emergency department as their primary care. It's not necessarily intended or designed to be that way, but that's just what ends up happening by default because they don't have that established relationship with a primary care physician or advanced practice provider like a nurse practitioner or a physician assistant. Basically, the primary care is your center point, your key connector of your healthcare services. So if you have an established relationship with a primary care provider, then they can help you with your chronic disease management, your optimal wellness or prevention, your annual visits, as well as, coordinating medications, supplements, any referrals to, say, a specialist like a cardiologist, oncologist, orthopedic, whatever it may be, even testing for X-ray imaging, labs, all of those things. The interpretation of those health results and kind of having that one person or team who helps coordinate all of your care, that's really what primary care is intended to be and what those services are. Again, the challenge is a lot of people don't have a primary care team or physician.
So is that a driver in cost?
Oh, absolutely. In fact, there's been many studies that show that people who are actively engaged with their primary care physician or primary care team actually spend significantly less over their life on healthcare expenditures. And in our current system, and this is where we get a little complex, but I'll try to keep it at a baseline level, is over 90% of the funding that is associated with the $4.5 trillion that is spent on healthcare expenditures in the United States annually is spent on chronic disease management.
Wow.
So basically it's for that, non-preventative care. So the bulk of the cost occurs in that, chronic disease or emergency state. And so that's where all the cost is. So if you're able to spend more time and energy in that front end, then it's going to cost you way less on the back end. Plus, not just in health savings, but in your quality of life, you're going to have more likely to, screen or have preventative findings sooner when they'll be easier to diagnose, treat, or redirect. You'll be able to be proactive in your approach instead of, waiting until it's a reactive situation. And so that could lead to less sick time at work, higher immunity level when illnesses come. It could be your productivity, your sleep, anything could be tied and connected with that primary care that improves your quality of life.
one of the analogies I use is preventative maintenance on your car. We all regularly go for our oil changes. We get our tires rotated. We get new tires. We do get new windshield wipers. We do preventative things because we are trying to extend the life of that vehicle and make it operate at an optimal level for longer. And you don't use your insurance for those things. You pay out-of-pocket cash for preventative things, for car maintenance, because you want it to last longer and work at an optimal level. But for whatever reason, in healthcare, the American health care system, we're not conditioned to think about that. We're conditioned to wait until the wheels fall off, till we have a major issue before we actually start, diving in and trying to figure out what is going on. And so that's where a lot of that, just any primary care can be so beneficial for everyone.
Yeah, there's no question. I love to use that example too. So it's funny to hear you mention that. But your home, auto, and health insurance are like structured completely differently. You use the example of your tire rotations or oil changes, but even like problems. When you have auto insurance, if you need to replace your tires, which now a set of tires could be over $1,000 real easy, there's no insurance submission for that. That's your out-of-pocket expense. But let's say your transmission goes bad. You've got a Jeep that you've had for 20 years, and that transmission goes bad. Unless you purchase some weird, policy that most people don't even know about, you're not going to get any support with the $5,000 replacement cost to, change that transmission. And so all of those costs you're essentially having a catastrophic insurance. Your auto insurance is in case you get in a wreck, in case you total your car, or if you have a significant damage. And so health insurance is not set up that way. I mean, you're having a catastrophic plan. Some people do that. But what it does is, basically covers you in case you have cancer or heart disease or a major illness.
Have a baby,
sure. But most people, have a more traditional insurance plan, either through their employer or through the open marketplace. And it's still a high deductible. It's still a significant amount of money every time you go for an appointment or a doctor. And you're essentially decentivized to go and have those preventative appointments, because you're going to have cash out of pocket until you've hit your deductible, and you're already paying high premiums every single month. So you're paying high premiums, you're paying until you hit your deductible, there's co-pays, there's office visit fees, there's co-insurance, all of these things add up, and all you're seeing is money go in and out of your pocket. Whereas if you don't go to the doctor, then your premiums, all you're paying, and you still have insurance for that catastrophic plan. So it is kind of it's an incredibly complex structure and system, and there's many reasons for that. And I want to say as well, there's no perfect system. People love to point to other countries and think they've got it all figured out. I promise you they don't. There's a balance of access, experience, cost, and outcomes.
Yes.
That is incredibly complex and nearly impossible to balance perfectly. And so, they do this in Italy, or they do this in Canada, or they do this in Mexico, and they do this in America. There is no perfect system that balances all of those four things that I just described perfectly. And so one of the challenges here in the U.S. is we have the mentality of we want it, and we want it now, and we want it to be exceptional.
That's right.
And that's our mindset. And I'm not saying we shouldn't have that mindset, but at the same time, it does lend to, okay, you're going to sacrifice something if you do that. And so a lot of times that sacrifice is cost. And so you want to have your knee replacement next week instead of waiting for 9 months, a year, 2 years, and maybe another country, then you're going to pay for that. And so there's a structure in place that makes it very complex to navigate all of those things. So my intent with anything I say today is not to necessarily like bash or say that the system is broken. It is complex. It is difficult to navigate, and surely it can be improved. We can have better outcomes. We can continually improve, like I said.
I regularly say the system is broken. I would just like to say that Jessica personally says that the system is broken, but I say it because a lot of times patients are frustrated because I can't tell you how many of my friends and family and then people we just see at SALT that come through the door, and they're frustrated because they haven't been able to find the answers. You know, they've been bounced around from specialist to specialist, that no one has the time or the resources to be able to dive in with them. And then also from a provider side, I mean, we have friends and family who are healthcare providers, and when you are bound by the traditional model, and you can dive into that a little bit for us, you have pretty strict parameters about what you can and cannot do if you want to get paid. And that's a real problem. And to me, I think it is broken. Maybe that's not the right word to use, and maybe you and Dr. Herbst might have something different to say, but there is an issue there. And I think what I love about Salt Health is Dr. Herbst and you and I saw that we didn't necessarily love the way something was working, so we wanted to do something different. And this was our getting out there in the free market and saying, all right, we want to be able to offer something different. So I don't know, talk a little bit.
Yeah, in fact, it's funny. I had some notes because I actually wanted to potentially read something if it came up. There's a lot of attention right now on the U.S. healthcare system, and there should be. So you say it's broken, and technically it is. Yes, I understand that. But there's a lot of positive momentum and excitement about, and forget politics. People get too focused on things. The bottom line is do we want us as U.S. citizens, as Americans, and our children, our families, do we want them to be healthier?
Yes.
The answer is yes.
Have that conversation.
Yes, the answer is yes. So it doesn't matter if you are Democrat, Republican, Independent. It doesn't matter if you are
Libertarian,
15, 14, 50, 100. Does not matter. We should be able to have a conversation in our country about we have to do something different. So I gave some alarming stats, but I really didn't go into the detail of it. So the brokenness is really now in that 60% or more people have a chronic condition in the U.S. and a third have more than one chronic condition. And so when you compare that to 50 years ago, there's dramatic dramatic increases in those numbers. Again, terrifying. So if we're looking at childhood obesity rates, we're looking at, things that are impacting our health. There's some really scary statistics, and the trending
immune diseases, autism, these things have gone off the charts.
Absolutely.
Just in the last, how many years? 25 years?
Sure. I mean, but if you look at it and you say, okay, can we continue at those same alarming rates over the next 25 years? The answer is no. So again, that conversation has to be had. We have to do something different. And it was cool to look back and say, okay, we started having these dreams about Salt Health and about changing, the traditional healthcare model and
especially primary care, changing primary care at a fundamental level. Because I think Dr. Herbst and you and I, we all agree that it's those foundations, that there's all these specialties. And I mean, when you're in the hospital and all of that, America really is the best of the best. But as far as that primary care, that setting that foundation of really walking with people through life, that's where that foundation is. If that's cracked, then, as you go down the road, it's only going to get worse.
Yeah, absolutely. And again, we knew those cracks were there. We knew the challenges were there many years ago, as a lot of people did. I just wanted to make the note that it's clearly getting a lot of attention right now, and I think that's terrific. But this is not a new problem. And this is not something, so it's, again, great to have the attention, glad we're talking about it. But back in 2016, 17, 18, when we were really diving deep into the concept of Salt Health, coming up with a full business plan, how are we going to implement this? This is a couple of excerpts from our business plan back in 2017.
I can't believe you're bringing it.
And so I want to read it because, again, this is not a new thing. So I'll just read for a second. The overall quality of an American's health has suffered in recent years. Chronic illness has become commonplace, and the search for health and wellness has become too costly. Our nation has seen a dramatic increase in childhood obesity, mood disorders, allergies, autoimmune, inflammatory disorders, heart disease, digestive disorders, and cancer. The traditional fee-for-service model pressures the physicians to see more patients, contributes to escalating healthcare costs, and demands non-productive time administrating complicated billing procedures. The average family medicine or primary care physician cares for more than 2,500 or more patients, does not allow adequate time with those patients and outcomes. This traditional medicine has become reactive instead of proactive. So this was us recognizing, acknowledging it, talking about it. Now we've got over 5 years of experience working with patients, partnering with them to live healthier lives, seeing outcomes, helping people optimize their health, focus on that preventative approach. And there's so much work to be done. But this was our mission. This was our goal.
Would you say that this is still pertinent?
Oh, it's even more pertinent.
I mean, we were like prophets and we didn't even... No. Okay.
So, I mean, again, I think it's one of those deals. You have to look at it from an entire, big picture. This has been a freight train coming for a long time.
So we weren't so prophetic. We just could see the signs. I'm just joking, by the way.
Sure, but I do think it's important to acknowledge that you have to have early adopters in anything. And the fact that Dr. Herbst and you and I wanted to change the way something was done at this level, I love that we have 5 years of experience now, operating in a way that will hopefully make a significant impact. We know it's making an impact with the customers and team members and, our patients and members at Salt Health. But we want to have this to be expanded and scaled to make a larger impact across the entire country.
Well, and part of the reason I started this podcast is just to have this conversation because I think a lot of people are starting to ask questions like, do I have to live with these things? Is it normal to age like this? I've heard the statistic that our generation is the first generation where the quality and longevity is actually decreasing in life for the first generation. Whoa, that's a big deal. We spend more on healthcare than any other nation in the world, and our quality of life and longevity is going down. So for the family practice providers and primary care providers who are out there doing the hard work, who are trying to lay that foundation and help people get well, what are the factors from an administrative point of view, from a payer standpoint, that are tying people's hands, both the patient's hands and the provider's hands? What for the layperson, what does that look like?
So part of what makes the healthcare system broken, as you like to call it, is the payment system. I mean, in fact, it was kind of funny. I was having a conversation with someone literally today about an experience they had, going to the hospital and getting an outrageously large medical bill. And so that, I think, is one of the reasons, again, we really wanted to at Salt Health be transparent. This is your cost, so any tests that we want to run or that you have the opportunity to get insight into, what the cost is going to be, what your monthly membership rate's going to be. You're back in control of being able to make decisions rather than finding out after the fact that you had to pay $100 for 2 aspirin in the hospital. And so it's an incredibly complex system. And I don't want to bore anybody, but I do think there could be some good insights that would help people to understand and navigate.
On the Jordan technicality. This is the meat of what we need.
So physicians and hospitals and other delivery systems are paid in different ways. So I'll start with physicians. Physicians are really paid off of something called a relative value unit, or an RVU. Relative value units try to place and balance a value associated with the complexity of care delivered. So that could be resources, time, administrative burden, all of the different types of things. And so more complex surgeries, procedures, things like that have a higher weighted relative value unit. A preventative or primary care visit is going to have a much lower weighted relative value unit. Well, CMS, Centers for Medicare and Medicaid Services.
So the government payers.
Okay. Congress actually sets a relative value payment factor that is through their budget, and it's adjusted annually. And basically, those higher weighted values have a payment that's associated with it. And so, of course, someone doing a brain surgery is going to receive a higher RVU and payment associated with that than someone doing a wellness visit. However, that RVU structure really has three problems that are fairly obvious. Anybody could Google or look at what works well, what doesn't work well with the RVU payment system with physicians. The first would be is that
you got people that are going to check you.
No, it's fine. That's fine. Go ahead. The first is going to be it prioritizes volume, so quantity over quality. There's no question about it. Someone who sees a whole bunch of patients or does a whole bunch of complex surgical cases going to get more RVUs and going to get more compensation. So there's somewhat of an incentive to increase those RVUs as much as possible. And you can compare those, say an orthopedic surgeon, two of them are in the same group. One might produce 10,000 RVUs and one might produce 8,000 RVUs. Well, the one who produces 10,000 RVUs is going to make more money. So again, maybe that 10,000 RVU physician still does better quality than the 8,000 physician. So it's not an individual physician comment. It's more of a structure comment that in general, it's a system that bases on volume and quantity more so than on quality outcomes.
Okay.
So that's the first thing. The second would be is that there is an undervaluation of primary care services. So
I'll agree with that.
So again, a surgical procedure is going to have a much larger relative value unit than a preventative. Well, the point should be though, is how do we get people to prioritize those lower valued RVU visits so that they don't ever get to where they need those surgical procedures and those chronic disease managements. And so again, the system is kind of structured where a primary care physician would have to see 70 patients a day to make anywhere near the same amount of compensation as maybe a specialist. Well, it's not feasible, it's not possible, but still to increase the RVUs for a patient, for a physician who's in primary care, they have to see more patients. Well, seeing more patients means less time per patient. Then you get into the system of, okay, how do I have quality outcomes? How do I make progress in partnership with a patient if I only have, which is the national average, 6 to 8 minutes actually in the room with a patient? You can't get to that root cause. You can't get to that deep assessment and analysis. You go to the quick fix items, which is here's a referral or here's a prescription, and then you move on to the next patient. Again, this is not the physician's fault. I'm not suggesting that they're not practicing good medicine. I'm saying that the system is structured in a way that it devalues those wellness and preventative or primary care visits because they just have a lower RVU value.
And if they want to get paid for their time, which
exactly
physicians have those too.
Yes.
If they get paid for their time, they need to see as many as possible.
And the third thing that would be kind of the RVU, issue is that there's so much red tape. So when it comes to administrative burden, billing, coding, all of those different types of things. So that system, again, puts it good to get paid. Yeah. So again, if you're saying what's wrong with the RVU system, I would say three things: prioritizing volume over outcomes, devaluing of primary care, and wellness services. And then three would be, recognizing there's so much administrative billing, coding, red tape associated with that process. So those are things that I would look at as the physician payment structure that maybe a lot of people don't know how that works.
I love how you described that. I don't know that I've ever heard you say that so succinctly. I mean, it's very...
Let's see, I could add a couple hours to it. We can go a little bit...
No, we're good. But I love that because we live in a great country. I love America. And so one of the great things is we feel like that system is broken. And the only way it's going to change is when the consumer demands it. And so it's great because once we understand that, man, if we can prioritize this preventative primary care, if we can keep our bodies healthy, if we can teach our children to live healthy from the early age and not have to make dramatic changes later on in their lives, then later on, we're going to have better outcomes. We're going to decrease healthcare costs. Right now, it sounds like from what you're saying that the benefit is really when people are sick, that you get more money, the system gets more money.
Sure.
I'm not saying for individuals.
Sure.
I know individuals are desperately trying to keep people well, but as a system, the system is built to make more money when people are sick, because that's where the money is. And so you wait until the wheels fall off, as we say, until you're extremely sick. I kind of grew up in a family, you go to the hospital in an ambulance or a hearse. There's not any in between. You waited until you were so sick, and mom might kind of doctor you at home, but that was about it. And so I myself had to change my mindset about that, about, proactively. And so by stepping outside of that government payer system, which most healthcare is run by, is that what I understand?
Well, even the insurers, so like a Blue Cross or United, like their payment systems still often follow, the government payers.
So even if you're not on Medicare or Medicaid, your health insurance is still following that same model?
Well, for like a reimbursement of services, yeah. So it's not like, in the past that there were insurance contracts and things that were significantly more, but I'll explain that a little bit more when we talk about the hospital reimbursement as well in just a second. But I do want to say, you teed it up, so I don't want to miss the opportunity. And that is the three issues kind of with that RVU model and that payment model with physicians. It's the reason that direct primary care or concierge medicine, some people, intertwine the two. They are technically separate, but it's the reason it was really created and now is becoming more popular with physicians. Because one, and patients, of course, but the point is the consumer, just like you said, is in charge of, their funds. So do I want this service? Do I want this experience? Do I want this relationship with this professional, with a physician or the primary care team? So now you're prioritizing not volume, but quality. So if you don't do a good job, I'll stop coming to you, I'll stop paying you, and I'll go find someone else, again, driven by that consumer. Next, the undervaluation of primary care. Well, that's what you're paying for. You're now deciding, okay, well, I'm paying this for a monthly access or fee, or these are the services I'm consuming that I choose. You determine whether it's worth the value of payment, not someone in Oregon who's answering a phone call, who's not a medical professional at all and is just reading from a code as to whether that should be approved by insurance or not, or by Medicare.
Yeah, he's talking about some of that red tape that on the back side, the administrative side has to go through. In case you didn't know that, explain that.
And that's the third thing. So in a direct primary care model, Salt Health doesn't even have billers and coders. We don't have to employ and go through those red tapes and fight insurance denials. There are teams of people in clinics and in hospitals that literally all they do is fight with insurance companies and fight over minor little coding differences or changes. And so the model in that structure really, creates an opportunity where you can solve some of those issues associated with the RVU model.